Welcome to the Cancer Support Suffolk podcast. Join me, Mark Murphy, and my brilliant guests as we talk about life before, during and after cancer. Hello, I'm Mark Murphy, the CEO of Cancer Support Suffolk, and welcome to our brand new podcast supported by the Suffolk Community Foundation and the Suffolk and North East Essex Integrated Care Board. Every month we'll be talking to people who've had a cancer diagnosis and they'll be sharing their personal journeys with us. We'll also be talking to health professionals for all the latest news on the treatment of cancer. This month we're looking at prostate cancer. With me are John and Adrian, who've both been diagnosed. Also Chris Booth from the group CHAPS and Peter Lobley, who's Macmillan Urology Nurse Specialist. Welcome all of you to our podcast today in our Cancer Wellbeing Hub in central Ipswich. Apologise in advance if a bus or an ambulance goes past. We'll just carry on regardless.
Absolutely.
This is our lovely working hub in central Ipswich. Adrian and John, if I can start with you first of all, and you're very happy to share your journeys of prostate cancer.
Absolutely.
Yes.
And Adrian, can we start with you? What was the first signs that something was up for you?
Well, it's weird really because as I turned 65, I got notification from my surgery saying I'm entitled to a well person's checkup, which I went for. And he didn't check for my prostate. And I came away thinking, well, that was a bit weird. They asked me again when I was 62 years later, when I was 67, and again it got to the end of the examination and he hadn't done it. So I said, are you going to check my prostate? And he said, why? So I said, well, it's the biggest killer of men over 60, isn't it? He said, oh, all right then, go behind the curtain and get prepared. Anyway, he did the duty and said, oh, it's a little bit enlarged, so I'll have to send you for a blood test.
This was a physical check,
Yes.
the finger up the bottom, wasn't it? Yeah.
So if I hadn't have asked at that time, I don't know when it or if it would have ever been picked up. From that, I had a blood test. I had a raised PSA level. They then said, we're going to book you in for an MRI scan, which was the end of March 2020, and we went into lockdown a week beforehand, so I had to wait until June type. And then they said they were going to book me in for a biopsy. By then, I twigged that there must be something wrong. I had the biopsy, and I went and see the specialist, and he sat in front of his laptop and he goes, oh yeah, you've got cancer. And I thought, well, that's a nice way of telling me, but I was prepared for him to say that anyway, so it didn't come as a shock. So that's how it all started. I was taken into another office and a nurse gave me all the options, gave me some paperwork, said, go home, talk about it with your family, let us know in a couple of days what you want to do. I went back. My girlfriend and her daughters, after having cried a bit, said, well, you got to have it out, get rid of it. You don't want it in your body, do you? So I rang up and said, that's what I want to go for. Then the nurse I spoke to said, we're going to get a consultant from Cambridge to give you a ring. And he rang 2 or 3 days later and said, why do you want to go for the op? So I told him. He says, well, I've been looking at your results and it's a very mild form of cancer. He said, I don't think that in 10 years' time it's going to be any worse. And the chances are when you die, it won't be of prostate cancer. He said, I would advise you to do active surveillance, and explain what that was, having blood tests every 3 months. And so I thought, and obviously there are side effects to any kind of treatment, whether it's up or radiotherapy or whatever you have. So I thought, okay, well, if he suggested that, that's what I'm going to go for. And I've been doing that since 2020. I've been having blood tests I had one recently, 3 weeks ago. I got rung by the urology department. They told me my PSA level had gone up slightly to 9.3 from 9, but they said there's still nothing to worry about. So I'm still going down that road.
That's the route you've chosen, yeah. John, what was your trigger for thinking something was wrong?
March 2018, one weekend, one Saturday. I can't recall exactly what I was doing, but I'd been messing around on the floor, I know. And I went to the toilet and it was blood. Right. First thing, said to Anita, said, don't like this. This is not right. Yeah, absolutely. Could be an infection. I said, Monday morning, I shall make an appointment and go down to the doctors. So off I trotted. Sort of one of the GPs, my local practice, she said, possibly we'll send off a urine sample for infection. She said, but if it isn't, we will have the results on Wednesday. On Thursday, you will be at urology at Ipswich Hospital. It's that quick. It wasn't an infection. I was at urology on the Thursday, and I was introduced to Peter at that time, to be fair, and he guided me through everything that I needed to do. I had a biopsy with Kate Moore, and that was after the finger examination had shown that there was some kind of lump on my prostate. And from then on, it was a case of going down, being formally diagnosed. And I remember this because it was my daughter's birthday, 10th of April, when I was formally diagnosed, when I think it was Mr. Yardy, who actually said, Mr. Rawling, you have got prostate cancer. I said, well, okay, then what do we do now? He said, down to Peter. And he said, Peter will be able to guide you through your options at the present time, which they are. And one of mine was to go off to, I went to Adam Brooks and spoke to a consultant there. And again, it was one of those things, you make the decision, Mr. Rawling. It's up to you what treatment you have. I couldn't make that decision. I had terrible trouble. I stopped off at Bury with my wife on the way home. And in fact, we made a phone call to Peter to ask him if we can meet up just to talk through. And it was through Peter's advice that I actually was able to come to a decision as to the fact that I was going to have radiotherapy. My PSA score at that time was 21.9, so it was extremely high. And yes, there was cancer was there, and a really high Gleason score, which I think shows its aggressiveness as well. So yeah, it was, and from then on, I had 35 sessions of radiotherapy. Starting from the September, I had to go on holiday, came back in the September, October.
Well, I'll bring in Peter because you mentioned Peter here. Let's talk to Peter, who's a Macmillan Urology Nurse Specialist. Obviously, we won't go into personal details of John's case here, but from what you've heard of these two gentlemen, sometimes there are symptoms, sometimes there are not.
More often than not, there are no symptoms for patients that we are diagnosing now. Genuine symptoms of prostate cancer, I would say. The PSA blood test is one of the key indicators to trigger off further investigations.
And Chris Booth from CHAPS. Chris, you are a former urologist yourself, and you and your organisation were on PSA checks for men to go to because we are reluctant to come forward to do things. You go to football grounds, you go to the Freemasons Hall, which is a couple of doors up from us here, you go to all sorts of different places to get people to have that PSA check. Why is it so important to you? Is it because of the no symptom side of things?
I think there are a number of reasons. Adrian, you said your doctor was reluctant to do a check.
He was, yeah.
Prostate cancer, as you all know, it's now the commonest major cancer in the country. We have poor cure rates when compared with our European neighbours and so on. And this is really because of lack of awareness and lack of access to good care. Once you're into the system, as I think you saw, you go through it extremely quickly and you get given all the right options. Do you want to have surgery? Do you want to have radiotherapy, etc.? And from what I've heard, I think you've chosen exactly the right option. And you've had the advantage of a clinical nurse specialist being able to, if you like, mentor you through what is quite a difficult process.
Absolutely.
But at the moment, the difficulty, as far as I can see, is getting access to the system. You may be able to get PSA tests from your GP, but you may have to beat the door down more or less to get it, because I was at a meeting yesterday with public health consultants and so on, and the public health consultants were not exactly saying anything wrong, but they were throwing cold water on the idea of PSA testing and whether we should have a comprehensive national screening program. And when you've got public health saying that, when you've got no clear guidance from the NHS, such as NICE and the so-called Prostate Cancer Risk Management Program, which goes out to GPs, but it isn't clear, easy to follow advice. So your GPs are then in a situation, what do? They're not getting good guidance, and that then reflects on your access to what is basically a very simple test. And as Peter said, the majority of men with early prostate cancer, and by early I mean it's still inside the gland and it's still at a stage where you can cure it, usually quite easily. The majority of early prostate cancers don't produce any symptoms at all. It's only late stage prostate cancer that tends to produce symptoms, and by late we mean it's got outside the prostate and it may well not be curable. And the big problem in this country, is that half of the men that we diagnose with prostate cancer are late stage, 49% to be exact. So that's the big problem. So we need to raise awareness, not just with men themselves, but the professionals, GPs. And ideally, I think we should have a prostate cancer screening service similar to what we have for breast cancer and so on.
Well, John's sticking his thumb up there. I mean, what do you two boys think of that? Should there be two thumbs going up? I think mine has as well.
No, I'm just thinking of thumb going up.
Yeah. Should there be a national screening program then?
Yeah, absolutely there should. I mean, I don't know. I'm not medically trained at all. And I don't know exactly how reliable you may feel that the PSA score is, or just a digit up the bottom is. And perhaps there should be some other further blood test which could more define perhaps a screening program. I don't know, but I do believe that there should be.
Peter, what are your thoughts on that?
There was always the belief many, many years ago that if you PSA'd everybody, that you wouldn't find enough cancers. That was the party line, and that's why we never did it. It produced too many false positives, too many false negatives. But actually, I think the evidence we've seen from CHAPS differs from that. And I think we know when CHAPS do an event that we will get an increased number of diagnosis. We do get a lot more referrals, and those referrals, a lot of them we can say, yeah, we've done your PSA, we've sent you straight to an MRI. We'll promise you an MRI within 10 days of referral, yeah? And from that we can say, no, everything's fine, we'll just keep an eye on your PSA. Or no, we need to do further investigations. So I don't think the status quo is meeting the needs of men.
You feel that there
I don't know what should be next, but I know that what we've got isn't, and it's not universal. Our health authority is huge now, and our trust is huge, and we should have the same level of care no matter where you are. And our hospital trust goes from Jaywick to Aldeburgh and nearly to Southwold, and actually you get different levels of care from there, and I think we should get more universal care to begin with, and then increased care.
Adrian, you want to come in there?
I just wondered that the tragic loss of the likes of Bill Turnbull and Len Goodman, and also the cricketer Bob Willis, and even they mentioned it with the present king when they mentioned prostate cancer. Then that must bring it a bit more to the fore for people, don't you think?
We had 60 more bookings the day after King Charles had announced that he was having prostate trouble. Yeah, in a day.
And you got to remember, Bill Turnbull actually kept on saying he was proud that he never went near a GP for 5 years. And that's because that's a mark of his health, as opposed to going and having chats with the GP.
And particularly blokes. I mean, we're all blokes together on this particular podcast today. And, I'm not keen to go. None of us are keen to go. We don't like talking to our friends about ailments and things. And, we've got to learn to be much more open about things. Chris, I want to just challenge you a little bit on the testing that you do, the PSA tests. So you do a blood test when people come along to one of your events?
Yes, it's a simple PSA blood test. Unfortunately, the finger up the backside in terms of screening for prostate cancer is really of no value at all, because early prostate cancers, the gland feels normal. Yes, you can estimate the size of the prostate, because the majority of men who have an abnormal PSA have an abnormal PSA because their prostate has enlarged due to this very common condition that most of us get as we get older, benign enlargement of the prostate. In fact, that brings me around to this concept of the PSA test, false positives,
well, that's
false
just what I was
negatives.
going to challenge you about there, because that's, I've done a lot of research into this since taking over the charity, and some people have said, we should all be having a PSA test, and others said, well, sometimes there's a false positive, sometimes there's a false negative. How do you justify that? Is it worth doing?
The PSA is the absolute starting point of everything. You don't get anywhere unless you've had a PSA test, frankly. But to label PSA tests as false positives and false negatives in cancer terms is completely misleading. PSA is a very good guide to something going on in your prostate. It's just it doesn't tell you what. It is not a discriminating test for prostate cancer. It's prostate-specific antigen, but it's not prostate cancer-specific antigen. The definitive test, the diagnostic test, is first and foremost the MRI scan. An MRI is over 90% accurate in telling you if you have got prostate cancer, and over 90% accurate in telling you that you've not got prostate cancer. And if there's any doubt about it, or we think you have got cancer, then you go on and have a diagnostic biopsy of the prostate done to give you the full picture. But to label PSA and say false positives and false negatives, I think is really, it's a misnomer.
There is some
and
concern in the health service about that, though, isn't there?
Oh, totally. The problem with the health service, if you like, is that we don't have enough MRI capacity, I don't think, to run a national screening program. But until we do, where do you start? Now, you start with a PSA. Yes, it would be nice to have a more accurate test. And at the moment, there are more accurate tests, but a PSA costs you a few pounds, whereas the more accurate tests that we have, which use genetics, things like this, they come into the mix. They're now costing you hundreds of pounds. And we're working with local laboratory in Cambridge on introducing this type of testing in as a second step after a PSA, so that hopefully we can use this and then reduce the number of MRI scans that we need to do, because over half the MRI scans that we do are normal.
Let's talk about some of the treatments available, because I think both John and Adrian have both said that there was a variety of things that they could do. I think if I was in that position, I would want the consultant or somebody to say to me, right, this is what you need to do. But from what you've both said, it seems as if you had choices. Is that often the case then, Peter?
So depending on the stage and the level of risk of the prostate cancer at diagnosis, you will be given a range of treatment choices. The gold standard treatment choices for radical treatment, that's treatment given with curative intent, is either surgery or radiotherapy. And they are both, in many cases, equivocal. So they both come out with roughly the same level of outcomes. So at which point we then look at the potential side effects from those treatments as well. And with support from a healthcare professional and the patient, they are given the choices, and that they need to make those choices themselves, of which way they would like to go. For some patients, there are only one choice, and there are some patients that can have up to 5 choices.
And the treatments are improving all the time, are they?
Yes, they are. Radiotherapy, hormone therapy, and the use of robotic surgery in prostatectomies has greatly improved both the time you spend in hospital, the reduced risk of impotence, and the reduced risk of incontinence of urine, which is of a great improvement for long-term survival rates.
Hopefully there'll be lots of men listening to this podcast, but also their partners as well. I'm going to ask each and every one of you what your advice would be, and I'll start with you, Chris, if that's okay. What sort of advice would you give to a man, let's say of a certain age? What sort of age do we need to start worrying about our prostate?
Well, the youngest chap that we've so far diagnosed with prostate cancer and who has had a radical prostatectomy was 41, and he didn't have any of the classic risk factors for prostate cancers. The risk factors that are always cited are black guys. I mean, as white men, we're White Caucasians here. We have a 1 in 8 lifetime risk of developing prostate cancer, not dying from it, but developing it. Black men, it's 1 in 4. They tend to get it at a younger age, tends to be more aggressive. The same goes for men who have a family history of prostate cancer. If your father's had it or your brother's had it, you've double the risk. And for the greater number of members of the family, that risk goes up exponentially. And what's frequently forgotten as well is if you've had breast cancer on your mother's side of the family or ovarian, you may inherit prostate cancer promoting genes. For instance, the BRCA2 gene that you'd get from your mother, that has a 50-50 chance of giving you aggressive prostate cancer in middle age. And this is all information that's out there. And Prostate Cancer UK, for instance, have been advertising the fact that they want to start prostate cancer screening trials, the so-called Transform trial, starting sometime this year. But this is only going to be targeted at black men and men with a family history. If you have a PSA done and you're at risk, you should certainly be starting in your 40s. For the rest of us, I think it's safe to start in your 50s, but you need to get a score on the door, because your score from your initial PSA is itself a determinant of risk.
So what would an average score be for someone? A healthy score, what would that be?
So if you're in your 50s, under 2, in your 60s, under 3, in your 70s, under 4. But if you go along and you're in your 50s and you've got a PSA of 3, well, yes, it's within the normal range, but that's high risk, because by next year it may be 4 and the year after 5, etc. So we use the initial PSA as a determinant of risk. So when you come to a CHAPS event and you get your result back, we give you your result. We tell you what your risk is. This is assuming that the result is normal. If it's abnormal, you need to get in and have an MRI PDQ. But if it's normal, we tell you what the result is. We tell you what your risk is. Most of us will be low risk, but if you're high risk, you need checking every year for a few years to see what's happening. If you're low risk, you only need a PSA somewhere between once every 3 to 5 years. That's quite safe. And you carry on like that till you get into your mid-70s, and if your PSA is still absolutely normal, you can stop screening, because inevitably you'll die of something, but it won't be from prostate cancer. If your PSA is less than 1, your risk of getting prostate cancer is minuscule. Well, it's negligible.
Yeah, Peter, what would advice be from you to someone who's listening today, a man or a partner of someone who's reluctant to go and get checked?
For those that are totally unclear, the Prostate Cancer UK website has a risk check, and you can actually put in a whole load of variables, and it will give you advice about what to do next as well. For those that want to check, I think for anybody over the age of 50 to 55, I think PSA, sometimes we get patients being referred to us with one solitary PSA, and that doesn't support and help us with what's going forward. If we have a series of PSAs over many years, we can understand it's a lot easier to support the patient.
And not be afraid to push in the way that Adrian did with his GP.
Yeah. And I want to put, you don't, for those that want to go to the GP to talk about PSAs, you don't have to have a digital rectal examination. You don't have to have it at any point in your diagnosis whilst awake. We can always do it once you're asleep, whilst we're doing biopsies. But you don't, if that's the one thing that's putting you off going asking for a PSA, you don't have to have both together.
When I had a check, a physical check of my prostate when I had a Wellman check, and it was like, oh, thank you. It was a bit like a carry-on moment almost, expected a daffodil to be sticking out there like on Frankie Howard in Carry On Nurse or whatever it was, but it wasn't particularly uncomfortable. It was just a bit, so, that was my personal experience anyway. So, but everybody's different, aren't they?
Yeah.
And some people have different comfort levels. So regular checks is what both of you are saying here.
Yeah.
John, when you look at your experience, what would you recommend to people listening?
Just get yourself checked. I don't care how you do it or where you go, whether it's through CHAPS, whether it's GP. If you're a certain age, just get yourself checked. It's as simple as that. If it's blunt, it's blunt, but do it.
Yeah, and you've been quite happy to speak about your diagnosis, and I know that you've been encouraging various people to have tests.
Yeah, absolutely. Yeah, I'm in an organisation where I'm able to do that and able to get to, we talked about Freemasons Hall up the road. So I've been able to talk to a lot of gents about getting themselves done. And it's surprising the number of that come back and said, I've done that, John, and thank you for just getting me, encouraging me to do that. Brilliant. And one or two have since been diagnosed and, they're on the road through their treatment and hopefully on the road to recovery as well. But just get yourself checked down. And I know that's, I can say it in hindsight now because I didn't do it. I waited until there was something there. But I didn't feel any symptoms. I didn't have any symptoms until I had that bleed. That was it.
What about you, Adrian?
Well, I've got a pair of rubber gloves, so I'm happy to do it for anybody.
Excellent. Gentle fingers.
When I was younger, if I was at a pub or somewhere, went to the toilet, and I got in there and there was an old man next to me, and the chances are I'd finish and be out of there and he'd still be there. And I just thought that was part and parcel of getting older. You just take longer to have a pee. But there's more to it than that. And it makes me wonder how many of these old boys, suffered afterwards through ignorance, And yes, when you think about what a woman has to go through, the kind of checks that a woman has to go through, that 10-second check is absolutely nothing. And if it's going to save your life, then what? It's a no-brainer, isn't it?
Yeah.
When my MRI was cancelled because of the lockdown, all right, and I knew there was something wrong, in that time, in that 2 months or whatever, because the word cancer, I went through all my stuff. I shredded a whole load of stuff. And I'm thinking, I don't want anyone to have to go through all my things if I'm not here. And it focuses the mind when you think, there's an end to your life ahead of you. Luckily, that didn't happen, but I wouldn't wish that on anybody. And like I say, with these well-known people who we've lost through ignorance, because like the likes of Bill didn't get his check till too late, Why? I just don't understand people. It's a bit like this morning. I did the school run, and there we had thick fog, and there's still people driving about without lights on, and it's just common sense, isn't it? So, what more can you say,
Chris?
Overall, our testing events, we're picking up prostate cancers at 1.8% of the men that we test. This is in thousands of men that our organisation has done, and a very, very similar percentage came out of an NHS pilot study conducted in Mid and South Essex this last year. This is actually twice the pickup rate from the breast cancer screening service, which is 0.9%. So there's significant disease out there. Now, when I talk about significant disease, this is disease that needs treating. Your situation's very interesting, Adrian, because you possibly had what we would call insignificant cancer, and it was possibly picked up through this blood test. And this is possibly what we would describe as one of the downsides of screening, because if you'd never known about this, you'd still be sitting here. You'd still hopefully be going on well into your 80s without any knowledge that you had this prostate cancer. Is it a threat? Should it be treated? You were nearly treated, but you then got a second opinion, as it were, in Cambridge, who said, no, actually, we can just keep an eye on this, and therefore you will avoid any of the potential side effects of treatment, potentially incontinence, potentially impotence, potentially damage to your bowel from radiotherapy or anything else like this. So that's a downside of screening. On the other hand, you're sitting next to a guy who's clearly benefited from screening and has been cured with radiotherapy. So you have to balance these. Now, at the moment, the benefit is clearly coming out on the side of screening, because the screening programs that have been running mainly in Europe, Northern Europe, are demonstrating that if you're in a screening program, and that means testing on a regular basis from 50s until you get into your 70s, not a one-off test, but regular testing, frequency determined by your risk. If you're in a program like this, you reduce your risk of dying from prostate cancer by a half. Now, you put that across our national statistics. So a national program, we estimate, would bring our death rate from 13,000 men a year, that's one death every 40 minutes, down to about 7,000 a year. If you only screen men who are at risk, i.e. black guys and men with a family history, that would reduce, we estimate, the number from about 13,000 down to about 11,500. So you can see where the benefits lie.
Chris, are there countries where there are screening programs in place that we could learn from?
Yes. Sweden, particularly, there are big regional studies that have gone on in Holland, Lithuania, Estonia, Latvia, where they have very high incidences. So these are the countries where we can learn from. And in fact, at the conference that we're running at the end of this March, we have one doctor coming over from Sweden who's running the so-called organized prostate testing program. screening is a tricky word in medical circles. So you see, we use words to get around it. And we have the urologist who's leading the whole screening program in Europe coming over. So hopefully we're continuing to educate the professionals.
Well, look, it's been fascinating. I'm so pleased that we've got a group of blokes together to talk about health. You know, Peter, that's so important, isn't it? You know, you're dealing with people on a daily basis who have had diagnosis with, you know, troubles with their waterworks or whatever we want to call it in the past. But to get people around a table like this and talk is just the right thing to be doing, isn't it? We should do more of this.
Our numbers have gone up since COVID. Our numbers dramatically have gone up, and it's only going one way. So we are hopefully diagnosing people earlier and giving them choices, as opposed to the further down the track you go down the disease process, the fewer choices are available to you. And yes, it's a horrible thing to have to make a choice about health, but at least you have that choice.
And Chris, I guess you've got a website for people to find out more about CHAPS and where you're going to be for your sessions?
chaps.uk.com, and all of our events are advertised there. Can I just mention, delighted that Peter's here, because to give credit to our local hospitals, Colchester and Ipswich were one of the first pair of hospitals, really, that were pioneers in developing the role of the clinical nurse specialist in guiding men through this difficult process. So that started back in the 1990s.
Well done for what you've done. And Adrian, yes?
So I just wanted to say, what was your quoted number for the amount of deaths per year? Was it 13,000?
At the moment, it's 13,688,
so
I think it was.
Around about 14. I was just thinking last night, watching the highlights of the Ipswich game. 28,000. Half of that stadium would be dead by, from prostate cancer. It's quite a harrowing thought, really.
On our previous podcast with Louise, who looks after the information centre at Ipswich and Colchester, she was saying, if all the cancers were caught early, it would be such a different outcome, Peter, wouldn't it? It's about that early detection. It really is.
Yeah.
Makes a huge difference.
It's the blood in the wee is the biggest, a one-off blood in the wee. Yes, I do a lot of prostate work, but I also do other urological cancers. And you talk to patients that have got advanced bladder cancer as well. I had a one-off episode of blood in the wee 6 months ago. And now that we've got, that certainly does change things. So, yeah, the quicker you get checked out, the better it's going. It's never going to get worse by getting checked out earlier.
Thank you all very much for joining us on our Cancer Support Suffolk podcast. John, Adrian, thank you very much. Chris from CHAPS, thank you very much. And Peter as well, Macmillan Urology Nurse Specialist, thank you very much for joining us on the programme today. Thanks for listening to this episode. And if you'd like more information about what we do at Cancer Support Suffolk, then go to our website. That's cancersupportsuffolk.co.uk, cancersupportsuffolk.co.uk, or call us on 01473 211 884. That's 01473 211 884. Cancer Support Suffolk is passionate about educating and supporting the people of Suffolk, and as a registered charity, we rely on donations and fundraising to be able to continue our vital work in the community. This podcast is the copyright of Cancer Support Suffolk and is produced and managed by podtalk.co.uk, supported by the Suffolk Community Foundation and the Suffolk North East Essex Integrated Care Board. Next month we'll be looking at bowel cancer, but for now, from all of us at Cancer Support Suffolk, goodbye.